Is it spicy?
No, not really. That's a good kid.
Okay, maybe we'll wait like one more minute and then we'll get going. All right, I am going to get started just in the interest of time. I'm just going to move everybody's faces off so I can't see you. Sorry. All right, so I am just standing in for Dr. Dunitz because she is not available right now. So we're going to go through directed acyclic graphs. This is going to be a high kind of 10,000 foot look. We're not really getting into details, but it's just to give you an idea of some of the things to think about, not only when you're looking at your journal articles, but also if you're going to do some research of your own. So there's lots of ways that biases can creep into clinical research. And this just shows you kind of, you can see some here when you're actually planning your trial, like depending on how you design your trial, you can look at actually biases during your trial. Lots of biases can creep in there. And you can also get biases when you look at your data analysis. And that's kind of confounding is the big one. And that's the one that we're going to cover in the next sort of 15 or 20 minutes. So what are DAGs? DAGs are directed acyclic graphs, and they're essentially causal diagrams. So they basically represent how variables relate to one another, especially when we're thinking of exposures and outcomes, because that's really what we're interested in and, what we've got in between to consider. So why are they useful? You can see this is kind of a complicated one, but they're useful to really understand, like I said, these relationships between your variables. In this case, it looks like they're looking at, education level and its association with the incidence of diabetes. But you can see there are lots of other variables that kind of get in the way, and we have to really consider, what are they doing so we know how to address them either in the design or in the analysis or, or both. Okay. So there are several types of ways that we can look at causal relationships. So we can look at randomized trials. And this is obviously, you know what a randomized trial is. There's no confounding, right? Because you have randomized your patients in the beginning of the trial. So there is no big confounders, right? So you can estimate the relationship between your exposure and your outcome using statistics. Just simple statistical models, right, that we don't have to look at confounding for. However, there are many studies that are non-randomized and mostly sort of observational studies where there will usually be confounding present. And you can really only estimate those causal relationships by using special statistical methods that are just for confounding. So that leads us to the next question is how do you choose what variable is a confounder? So this is where the DAGs come in. So directed acyclic graph, it's directed because all causal relationships have a direction. You have your exposure, or here's some other words for exposure, is causally related to your outcome or your disease, okay? If there's no arrow, it means there's no causal effect. So a lack of arrow is actually an important statement. So you have to really consider, where your arrows are going. If there is one missing, is it meant to be missing? Acyclic because circularity does not exist, right? A variable cannot cause itself. There is no feedback loop in this situation. Each arrow only has one head pointing in the direction of, kind of time, if you like. So the effect of exposure on disease. So here's the most simplified form of a DAG. This assumes no confounding, right? We've got a direct effect of this exposure on this disease, right? We can use regression models for that. But obviously this is too simple, right? And in real life, things are a lot more complicated. So this is what, you can think of as a sort of a DAG. It's kind of complicated. We've got our exposure over here. We've got our disease or our outcome of interest over here. And we've got lots of pathways that can happen in between. And like I said, we're just going to talk about this one, really the confounding effect, but we also have to think about some of these others. So let's go with a research question. Is eating ice cream associated with drowning? Okay, so here's our causal diagram. Our exposure is ice cream, our outcome is drowning. We put that into, statistical package and we find, oh, look, the direct effect of our exposure of ice cream on drowning is a relative risk of 2. So you're 2 times more likely to drown if you eat ice cream. Okay, all right, well, that sounds kind of too simple, right? So what do we have to think about? Well, we have to think about a confounding variable or variables with an S, the common cause of both. So confounder is something that has an arrow going to the exposure and also has an arrow going to the drowning. So can anybody think of what a confounder in this case could be? You can just shout out because I can't see anybody. Nobody wants to take the step.
Is it like going to the beach?
Could be, yeah. So it could be.
Easy.
I mean, those are great. I've just chosen summer, right? It could hot day, beach, anything like that, right? You have to consider all of those, but for simplicity, I've just picked one. So in this case, I just picked summer, right? So summer is related to both the exposure and the outcome. That means we have to account for summer if we want to look at the effect of eating ice cream on drowning. And so when we do that, and we run that model again, we find the relative risk is 1. Remember, we've talked about risks before. So relative risk is 1, it's equality, right? There's no difference. Okay, so you have to think about those confounding variables because they can really change your outcome, your results. So what about this? So here's a study. We have a post-op complication rate that's much higher with the most skilled surgeons than in less skilled surgeons. But let's think about a confounder. What could be confounding that relationship? Any ideas?
The higher skilled surgeons are taking more complex cases.
Exactly. That's exactly. They might be more severe, they might be more complex. So this is a confounder. So we have to adjust for this variable in our model. Otherwise, we're going to get totally biased estimates, right? So similarly here, higher quality hospitals have higher mortality rates than lower quality hospitals. Right? And it's kind of the same thing, right? The complexity of the cases, the more complex cases go to the bigger, the more advanced hospitals, right? So we really have to think about this when you're planning a study or analyzing a study that's already been done. So confounding, the meaning of confounding in other languages is essentially confusion, mix-up, mistake. Okay, so that's why we have to really keep this on our radar. So we can think of confounding as confusion of effects. So here we have exposure and our outcome. We've got to consider what could be related to these two, all right? So like I said, the arrow has to be pointing to both the exposure and the outcome for it to be a confounder. So if you want to check that you have a confounder, there are 3 rules that you have to consider. You have to consider, is the variable associated with the exposure, meaning is the arrow going from the confounder to your exposure? Okay, if the answer is yes, we've got one of the criteria. Next, is the variable associated with the outcome? So you have to have this arrow going from confounder to outcome. If the answer is yes, then we've got 2 of those criteria. The third one is the variable caused by the exposure of interest? And this answer has to be no, right? So the confounder must not be caused by the exposure. So if the answer of that is no, then check, check, check. You've got your 3 criteria. You have a confounder. You have to deal with it. So let's run through an example here. Baldness and cardiovascular disease. So here's a study, men free from any cardiovascular disease. They were classified as either bald or not in the beginning. They were followed to see who developed cardiovascular disease and who does not. So first off, what kind of study is this? And if we go back a few of these sessions, hopefully somebody will remember. Anyone?
Is it a perspective?
Perspective, like a cohort study, right? Because we're following people to see what happens over time. Yeah, great. So here we go. We've got baldness and cardiovascular disease. We could run this on a model and we could get like a 3-fold increased risk of cardiovascular disease if you're bald. But that doesn't kind of sound right, right? We've got some confounders to think about. So does anybody know what could be an obvious confounder? What is related to both baldness, the arrow would point here, and also to CVD? Real obvious one.
Age.
Age, perfect. That's the one I picked. Okay, so let's test. Is it related? Yes, the arrow goes from age to baldness. Is it related to CVD? Yep, the arrow goes straight from age to CVD. Is age caused by baldness? No. So here we've got our 3 criteria. It's a confounder, okay? So how do we control for it? Well, let's just back up a little bit. We should have thought about this in the study design, right? So we could have done matching. We could have had a non-bald and a bald person matched for age, BMI, that kind of thing. We could have restricted to younger or older participants. There's limitations to doing this, of course. Or we could have randomized them. Instead of having an observational cohort, we could have randomized them. Or we could deal with it in the analysis, right? We could adjust, like a form of standardization is a form of age adjustment, or we could have stratified. We could have compared the incidence of CVD among people of having been bald, and then do the same thing in those who are not bald. So there's different ways you can do it. You just have to be aware when you're designing your study or when you're reading a study or analyzing a study. So we confuse the effect, right? Because if we're looking straight from baldness to CVD, and we got this, you know, odds risk or relative risk of 2, maybe not if we consider age. So if we consider age, we know it's a confounder because it goes, but the arrows go both to the exposure and the outcome. When we run that in the model, when we account for age as a confounder, look what happens. We now have no relationship between baldness and cardiovascular disease. It goes away. So we had complete confounding by age. So our results that we had before were completely explained by age. Okay, complete confounding. Doesn't always happen that way. I'll just show you another example. Looking at diet and heart disease, we know that poor diet can impact heart disease. One confounder could be smoking, right? So we adjust for smoking in the model, but look what happens. The relationship's still there, it's just weaker, right, between diet and heart disease. So there was partial confounding. So it's still really important to adjust for those confounders because they can change that relationship that you're looking for, okay? So back to our DAG again. I'm just going to touch very briefly on the moderator. The moderator, or in effect modifier, is a variable that changes the strength of the association between your exposure and your outcome. Okay, so it modifies. So in this case, we've got depression having a hazard ratio of 2 for dementia, development of dementia, but sex could be a modifier, right? So let's just stratify. We'll stratify into a group of females and a group of males, and let's look and see what happens. What we found here is that when we look at women, we find that the hazard ratio for dementia, if you have depression, is 2.3, but when we look at men, it's 1.4. So you can see that that was moderating. Sex was moderating that relationship between depression and dementia. Okay, so that's something that we have to look at, but that's different from a confounder. This is an effect modifier or a moderator. And there's also something called a mediator. A mediator is within our causal pathway, right? So we might have said the relationship between obesity and heart disease, but hypertension is actually in the middle of all of this, right? Because you could actually go from obesity through high blood pressure to heart disease, right? So this is on the pathway of causality, right? So it influences the outcome, and we need to understand the effect of that. We do not adjust for mediators. We estimate how much of the effect is going direct from obesity to heart disease and how much is going through the hypertension pathway. All right. So we can look at the direct effect, which is obviously that straight line, or we can look at the indirect, which is through our mediator. And so here's a real life example that we did in one of my studies quite a long time ago. We were looking at incident hypertensive disorders of pregnancy, and Galit and I sat and we looked at these DAGs and thought, well, how, what are the relationships between these variables? So we want to disentangle the relationship between maternal weight, development of hypertensive disorders of pregnancy, but we were particularly interested in this pregnancy snoring, like pregnancy onset snoring. So we drew this DAG and we thought we're going to, we'll analyze this. So we looked at the overall effect and we got this odds ratio of 2. Like, if you were overweight, there was a 2-fold increase in the odds of developing hypertensive disorders of pregnancy. We'd accounted for these variables down here. But we also wanted to look at the effect. Well, does something go through snoring during pregnancy? Because if it does, we could address that, right? We could maybe help people stop snoring. If it was OSA, we could treat them with APAP or something like that. So when we did that, we found through our models, when we did a mediation analysis, that actually we had a direct effect, of course, but we also had this indirect effect. And this indirect effect was explaining 15%, right, of the relationship. So that could be a huge deal, right? That means if we can address and prevent the snoring, we could remove 15% of what's going on here, right? Does that make sense? Okay, so I'm going to just stop there so we can move on to Journal Club, but there is actually a free online tool that you can draw and analyze causal diagrams. So that's the website for it. It's called Daggerty. It's quite useful and quite fun to play with, but I'm going to stop there and we can move over to our Journal Club.
Sounds good. I'm just going to take off my video so that way it runs smoothly. Can you guys see my slides?
Yeah.
And is it regular view or
Yes,
presenter view? Okay, sounds good. All right. So, so this is the article that I'm presenting. The acronym that they use is MENTA. MENTA program based on motivational interview to improve adherence to treatment of obstructive sleep apnea with CPAP. And they did a randomized control trial. I found this article in this is actually from I think Spain. That's where they did the study, and Open Respiratory Archives, and these were the authors. Oh, how did I do that? Oh, it's not moving. Oh, here you go. So kind of roadmap of how I want to go through this journal club. I think I kind of want to go through the background of why I picked this article. Looking into my motivation, the background of the actual study, basically have a recap of what the study findings and how they did the study, and also have some discussion on the strengths, limitations, and maybe possible next steps. So a background and motivation. So we do know a lot of times whenever we see patients for sleep disorder breathing, provide some counseling, that the first line treatment for obstructive sleep apnea is typically CPAP, and it's very effective as long as there's continued use. But a lot of times I think we're exploring the barriers to patients' adherence, because even though it's very effective, lack of adherence, I think a lot of times is the main problem. And so for me, a lot of my interest is in motivational interviewing. I think because my background is family medicine, I've done a lot of it in residency, and I think I notice I attract patients with that can benefit with motivational interviewing. So just a quick recap of what motivational interviewing is, or MI. It's basically exploring the patient's intrinsic motivation for a certain, let's just say, behavior change, and try to look at the resolve the patient's ambivalence, assess their readiness to change, and really build up their confidence for change. Like I said, For my motivation, I am motivated, and I picked this topic because of the cloud that I've encountered so far. I like to, my own practice style is having a shared decision making with the patient. I like to empower patients and really try to do my best, resist what I call a writing reflex, or try to correct them by telling people what to do. And motivational interviewing by itself, it's evidence-based approach to behavior change. And with motivational interviewing, it's applicable not just for behavior change with obstructive sleep apnea or PAP therapy, but it could be applied for a lot of different things, including smoking, obesity, and all of that. So what the paper looked into was having a sort of research question. They said, we know the CPAP is the most effective, CPAP is the most effective treatment for obstructive sleep apnea. And the aim of their study is really to determine if they've had some sort of educational and training program based on motivational interviewing with proper feedback. Would this improve adherence compared to the standard? So for just more explanation, MENTA, like I said, this was done in Spain. So it stands for Motivación y Entrevista para la Adherencia, so i.e. motivation and interview for adherence. And like I said, the goal of incorporating this MENTA program is see if it will improve adherence. And they try to take into account some variables related to the efficacy of the treatment and some sort of evaluation for quality of life. What they did was, it was a randomized controlled single center trial. And at the bottom, these were their inclusion criteria. So primarily adult patients, they went to this respiratory medicine department at this hospital, and they were enrolled within a 1-month span. Patients would have to be diagnosed with obstructive sleep apnea by PSG, and they are being recommended CPAP as a treatment. Patients have to be naive to this intervention, never tried PAP therapy before. They excluded patients that needs BiPAP ventilation or more advanced therapy, patients that are being recommended CPAP titration study, patients with concurrent COPD disorders, some cognitive challenges, cognitive disorders, as well as patients that are unable to provide consent or understand the participation, understand what they're doing to participate with the study. Before enrollment, patients were informed of the study and provided their consent to participate. So kind of looking into the standard CPAP school and a MENTA CPAP school. So I think looking into this paper, at least in Spain, the standard CPAP school is very similar to what we do here, i.e. The patients would typically meet with someone. So over there, it will be a nurse. It would be an 80-minute session. Typically, it looks like for them, it is more of 8 to 10 people. That includes family members if they want to come, let's just say a partner. They would, in that standard CPAP school, they would talk about basically what CPAP is, what's the goal, how to put on the mask, how to clean it, maintenance, some ways to triage if they're having difficulty, adjust the straps, that sort of thing. It's sort of done in kind of like a classroom setting, wherein someone will be demonstrating on the PAP use skills are being implemented, and then patients are given a chance to try it out for themselves for a few minutes and get them acclimated to that pressure. And then the typical follow-up will be 30 days and then followed by 90 days. And typically, like I said, it's done with a nurse. And with the standard CPAP school, it focuses on how to handle CPAP and how to really use it. The MENTA CPAP school is what they do is very similar to the standard CPAP school, wherein they would still go through the education. They would actually describe more on this, going through the symptoms of sleep apnea, how does CPAP work, how do you optimize the treatment, and then going over the mask, patients being able to put on the mask themselves, troubleshooting, cleaning, and all of that. The big difference is in the Menta CPAP school, the nurse is not directly telling patients what to do. They are not directly advocating for a behavior change, i.e., use your CPAP as described. Instead, they focus on exploring the patient's feelings about change, about wearing a CPAP, weighing on the pros and cons, and allow the patient to realize the discrepancy of their current risk behavior, i.e., not using their CPAP, and the patient's intrinsic goals. So the nurse that is doing the Menta CPAP school, they are trained by a sleep psychologist to kind of go through more motivational interviewing in the Menta CPAP school. Just for a brief recap on motivational interviewing. So I think all of us are very familiar with basically assessing the trans-theoretical model of change, i.e. looking into pre-contemplation, contemplation, determination, maintenance, and relapse of behavior, but kind of going through how they typically focus whenever people is doing motivational interviewing, i.e. the big things on the right is the person that's doing the motivational interviewing is they're establishing a connection with the patient. They're expressing empathy, asking open-ended questions, paraphrasing, reflecting on the patient's feelings, and then together agreeing on a plan. It's a more personalized feedback that is given to the patient. And like I said, the goal is having statements of self-motivation and honing into the patient's intrinsic motivation toward change. We kind of looked into basically what's a standard CPAP school and the Menta CPAP school. Both of them were in 80, the nurse would spend 80 minutes on each, and I will go through the study more in detail. And what the study did was they kind of looked at several outcomes. The main outcome they wanted to look into was what is the patient's adherence rate with their CPAP after 90 days. And they compared patients that went through the standard CPAP school that based on the number of hours of use on their CPAP that's being recorded, and then the one with the Menta CPAP school. And then, like I said, both of them, they spent 80 minutes. With the primary outcome, they also explored other secondary outcome. So they looked into motivation, for example, wherein they said, they asked questions such as, your doctor has diagnosed you with sleep apnea and have explained the treatment with CPAP as well as other lifestyle changes. What do you think about this? And then they would be sort of categorized based on their response on what model of change are they in? Are they in pre-contemplative or contemplative stage, that sort of thing. And they also had a questionnaire to go over patients' perceived competence. I did not see the question myself, but on the description of the study, they had a validated questionnaire looking into the patient's knowledge of their therapy. What is the risk of non-therapy expectations? What is their confidence of overcoming obstacles? And patients that have a positive score basically imply that their improved quality of life, this is what I put out as QOL, and maybe improved motivation. That's what they said. And then one of the other things they looked into for the quality of life is some sort of well-being scale questionnaire For the sleepiness scale, they use Epworth. They also use some emotional state, daily activities, and social relationship questionnaire, in which they ask good, normal, no change, bad. If you take into account your sleep problems, how would you say you are in terms of your mood, activities, social relationships? So it's kind of a more yes, no, good, that sort of question, and what the response was. So with their inclusion criteria, they were able to recruit initially 100 patients, but after the inclusion criteria, only 83 patients were able to fit in that study. And then they randomized them. And then in the next slide, I will show how they did the randomization and what's the breakdown of the patients. Half of them went to the CPAP school, and then half of them went to the Menta CPAP school. And then they did some questionnaires and then looked at their adherence afterwards. So kind of just looking over the breakdown of the results, I want to give people a chance to kind of look into the data. Anything that you guys have noticed? By the way, I can't really see faces. I'll just go through them. So with the 83 pages that they recruited, so from the very top, most of the patients are male. 60 of them were male. 32% of them went to the Menta CPAP school. The other one is a standard school. The other 23 patients were female. They for the standard, basically, what is the patient's average AHI? The average was 48.5, and then the standard deviation was 18.69. So that kind of translates to a range of about 30 to 61. So most of the patients they had were those with diagnosed severe sleep apnea. As for marital status, most of the patients were married. And then most of the patients completed primary school. And then most were active employment. And yeah, so I kind of looked into this in a way of comparing typical Ann Arbor patient population. I kind of had to look this up. Ann Arbor patient population, it says most there was, I think, race-wise was 69% white, and then they said 16% Asian, and the median age in Ann Arbor, I think because it's a college town, they said 27 years old. Primarily 50% are females and then 49% males. And then in Ann Arbor, I would say they said 46% of the population have a graduate degree. And then 34% are married and the rest are not. So some representation, but not very reflective of the Ann Arbor population in this recruitment that they had. And then just going back to the study, they looked into the primary outcome, which is, like I said, comparing the standard CPAP school and the Menta school after 90 days, what were the adherence looking like? So from this diagram and the little description here, the standard group, they were using their PAP therapy on average for about 4.4 hours compared to the patients that underwent the Menta school. The patients were using it on average of 6 hours. So it was basically the results were in favor of the Menta therapy. Other results that they looked into was, like I said, the adherence. They kind of looked into the relative risk, and it's greater than 1. which shows that if it's greater than 1 indicates that the event for this one is about 4 times, more than 4 times likely to occur in the Menta group. So i.e. they meant it as adherence is 4 times better with the Menta group than with the standard one. So that's what this shows, that it's greater than 1. And then just for a little recap, that CEP-CA, that was the questionnaire that I was telling you about the patients, how they evaluate their competence with their PAP therapy. And it was significantly more with the Menta group. And then same with the quality of life. There wasn't much change with the assessment of between the standard and the Menta when it comes to perceived sleepiness. Just a little side note, they did look into the 30 days adherence, and at that time, they looked and saw that it wasn't really significantly different between the standard group and then the Menta group. But 90 days, it was more significant and more in favor of the Menta group. So just for a conclusion with this paper and then the further next steps. So the Menta intervention that they looked into using motivational interviewing and having some sort of training program based on this concept shows they have solid results in terms of its efficacy. And not only it showed benefits in adherence, but also processes which can lead to successful adherence. So the things that they looked into was self-efficacy, patients' perceived competence with their PAP use for maintaining adherence. They saw that with positive results with other patient-reported outcomes, such as quality of life, better with Menta. They thought it was a very positive results. And some of the factors that they looked into, like the perceived competence, the emotional state, even social relationships, all of those were in favor. And they thought that these were closely related to better adherence than the standard PAP school. Like I said, for strength, I do think that it's very promising. They had a higher level of efficacy with the Menta group than with the standard one. And with the motivational interviewing, I think the strength is that it can be applicable to other disorders, not just for PAP therapy with obstructive sleep apnea. It can also be applied to insomnia, circadian rhythm, weight management, substance use disorder, and all of that. It's a very effective tool that can be used in healthcare. And this is the part where I think I want to discuss the limitations. So I think one of the big limitations that I was thinking of was it's a very short-term results. We have several patients that would be compliant maybe for the first couple of months, 3 months, and then they would no longer be adherent. So the study stopped at about 90 days. So we don't really know what are the long-term results of undergoing Menta versus the standard PAP school, for example. The other part is, like I said, I did not really see the questionnaires that they used themselves. They had a description of it, but I don't know the actual questions, how they asked the patients. The other limitations that I thought was sometimes when you know that you're going to be participating in a study, and that the patients could have been given some sort of implicit knowledge about the experimental group membership, maybe the nurse, I know they said they both were 80 minutes, possibly spent maybe more additional nurse time, having more attention with the mentor group. The other one was it's a single center design. It's only done in that specific hospital in Spain in a 30-day span. The Demographics, I would have a next slide for it just to kind of recap the breakdown of the patient population. They were primarily male. 60 out of the 83 people were male. Sex was different. It was primarily, I think, severe sleep apnea. What we're really trying to do is, can we trust the results that they've done? And then could there be alternative explanation of the success of the Menta that is not related to the Menta itself? So just kind of looking into the previous slide that I've mentioned before. I don't really think it's very specific to our current population. Most of the patients that they've had were, for example, 79% of them were married, primarily male. Most of them completed primary school only. They also, they did not really specifically include, they had an average of the age. So the patients were, so average age was 59, standard deviation of about 12. Is that 37? Yes, 37 to maybe about 71. I also think about with the patient demographics, older population may have more comorbidities that could lead them to maybe lower or higher adherence. So that was something that I was thinking of that could be affecting the study. Most of the patients that they've had were, I think, married. And sometimes when I think about our patients that we do see, a lot of times the married patients are more motivated with their use because of their partner, and they want to be able to go back and basically be back on the same bedroom, sleeping with their partner. So a little bit more motivated. One thing that I just also wanted to point out is I actually looked at this bottom one right here, risk factor for low adherence. I found a paper wherein they looked into different variables on what would be confounding factors, I say, or other factors that would promote low adherence. And they've said that the most direct correlated one was low AHI. And in that study that we've seen, they've only really looked into patients with severe sleep apnea with AHI greater than 30. Other possible factors where they've mentioned in another study that I saw was sex, age, and then the BMI. So I think the study itself was promising, and the way I see it is could be another tool, the way we can conduct and improve adherence for PAP therapy, but it's not the only tool. And I'm going to give people a chance to ask me questions if they have questions.
Thanks, Roma. I have a question for you. You know, it looks like this is kind of aspirational in terms of resource utilization. They had a psychologist train the nurse to employ the specific motivational interviewing techniques and other things. So I was wondering what your thoughts were on your experience in primary care about the types of resources that are needed to truly implement this type of system, and if you think something like this is implementable in a sleep clinic.
Yeah, no, that's a good question. Thank you, Dr. Shalgikar. So one of the other thing that I think is a barrier, maybe not really that applicable to us, is they would have, like I said, 8 to 10 patient group in a session, and they were able to spend 80 minutes just going over PAP therapy. I have participated looking into how our for example, RTs do it at the VA as a patient myself. I was also able to have some sort of PAP training as a patient, and they do not spend 80 minutes with you. And they really, you will be lucky because I do ask this for patients, you'd be lucky if they put the CPAP on your face and turn it on. And you would be lucky if they try out more than 2 masks, for example, because once they open that packet, they will give it to you. And then those masks are not cheap. So I think time is a limitation, cost is a limitation, and not really being able to do a lot of this one-on-one meeting with the patients. I think with my experience with primary care, even now I try to do bits and pieces of motivational interviewing, but you are not able to spend 80 minutes with a patient trying to come up with their intrinsic goal and letting them jump from pre-contemplative stage to a contemplative stage, and then they decide to do an action. It does take a lot of time. So I think there is some feasibility, but I think there's a lot of limitations that may not be that applicable for us.
Thanks.
Parts of that was a very nice distillation. Thank you. But parts of the paper were not as easy to follow as others, and one of them was I didn't really follow the exact regimen too well. To my understanding, the 80 minutes was similar in both arms of the study, and in the motivational interviewing, a good portion of the 80 minutes, I think it was more than half, was spent on the equipment questions and all that, and then there was like 20 minutes or 30 minutes, something like that, on the motivational interviewing. And then they were also vague. They said that what happens to follow-up, because part of motivational interviewing is the person administering it kind of becomes the friend, befriends the, to my eye, I call it befriends the patient, and, is doing regular calls or checkups with them, and not like we do it, at best 3 months later or something like that. I'm talking about frequently. And it was not so clear exactly, unless you understood it better. I do think that it's a very important question of how implementable it is. And I can say that we've been using a lot of it in Sleep Smart, and it's not easy. It's not easy to train the people who administer it. We have really experts on it, training them, and there's an assessment called OnePass that you can do, where you look at their session, at the coach's session with the patient, and then score them on this OnePass thing. And you can see, it scores like you get credit for asking open-ended questions, for reflection, for all the various elements. And it takes a while to train people up. And some people are better at it than others. And I will say it takes a lot of time. And they gave the average numbers, the average touch bases, I think it was 20 minutes for the follow-ups, if I'm remembering, but or maybe it was less, it was 15 or 20 minutes. And I think to do it right, you might even need longer than that. I think they include equipment issues in those sessions. All that said, I will say they did a trial and they found significant differences between groups. They mentioned one place how much it was. It was 4.6 hours, which is already not bad at their baseline. Went up to 6 hours in the group that got the MI. But anyway, I did find it interesting and very relevant to what we do if we could ever have the resources to implement. Did you?
Chime in and say, I think. Oh, sorry, Roma, you asked.
No, I was just curious if Roma had a better understanding than I did of what the follow-up was.
Oh yeah. And then I had a feeling I was gonna ask you, Dr. Arnett, for your thoughts as well afterwards. So I was on the same boat as you, Dr. Chervin, because I kept looking back and forth. Because it was also very unclear to me on how they did the follow-up, how much time was the follow-up. I do agree that it's not applicable. It's not in the same way we do here at least in the US, wherein the follow-up is with a physician or at least a provider and not with a nurse for compliance therapy. Because I do think one of the things that is very important with what we do is not just assessing the motivation, is looking into other barriers for PAP use. Was the mask comfortable? Was it effective? And that's not something that they look into. And I do agree with you. I have a lot of interest with motivational interviewing, and it is challenging. And a lot of times, just 20 minutes, that's what they said. 20 minutes was for the follow-up. But with us, sometimes with my experience, 20 minutes for the patients that I see typically is spent with just them crying. I haven't even gotten a chance to ask them questions, and then I still have to staff the patients. Um, so I do think it takes a lot of time, and then sometimes it's not really as applicable with us because we, with them, they're able to spend more time than what we can here at the sleep clinic. Sorry, Dr. Arnett.
No, that's good perspective, Rome. I was just gonna chime in and say, I think it's true for like a full bore MI approach. It does take a lot of time, but I think you can also incorporate elements of MI into your clinical interactions that can be relatively time limited. And I think that it's always useful to have the perspective of the trans theoretical model in your head, because I think we always assume because patients come to us that they're in action mode, when many of them are not necessarily in action mode. They're in contemplation, pre-contemplation. And so that's a useful perspective to try to understand where your patient is in terms of that behavior change spectrum. And also you can incorporating things like, like 0 to 10 scales, asking people where they fit on a certain scale with respect to treating. You could ask it generally, like with respect to treating their sleep apnea, how important is it for them to treat their sleep apnea? And whatever number they give you, you can have a quick conversation around that. They give you a 5. You can ask, why did you choose a 5 and not a 2? Or what would it take to get you to an 8? And these are quick interactions you can have that are grounded in motivational interviewing and can be really helpful to instill ambivalence in an individual, because really motivational interviewing is all about eliciting ambivalence and trying to help patients intrinsically work through that ambivalence, ideally in the right direction, but ideally in the direction you want, in a health positive direction, but not always. They may make a different decision, but it's about resolving that ambivalence. So those rating scales can be really helpful. And those are things I think you can do in the context of a sleep 15, 20-minute interaction. And certainly it's done in primary care all the time, these kinds of things. So
Yeah, I do like the rating scale. I've used them a lot. Asking patients, what's their confidence of being able to restart PAP therapy, for example, if they had a relapse. 0 to 10, 0 being no chance, I will not use it, 10 being yes, let's do it now. And I would have patients just like Dr. Arnett say, let's just say they say 5, for example, and then you ask them why 5, and then they may say, well, I was able to do it before for 3 months every single night, and so I know I can do it, that sort of question. So yeah, thank you for that perspective, Dr. Arnett.
Todd, do you want to comment on, you implied that there's full MI and there's shades of MI. What's the relationship between what patients are getting when we refer them to behavioral sleep medicine for focus on adherence? How much of it is MI-like and how much of it is?
it's a good question. I mean, it depends a little bit on the nature of the problem, I guess. We do have a pretty well-developed protocol that is MI based, that we used in that that randomized controlled trial that we published some years ago that Mark Aloya was the lead on, my colleague Mark Aloya. And we developed a pretty rigorous full protocol that's, I think it was based on seeing people early on in treatment, ideally, and identifying there's 2 relatively 45-minute, relatively robust therapy sessions. Depending on the issue, when they come to us, I wouldn't say we would necessarily unveil that whole protocol, but we would probably, again, use elements of it, and probably a lot of it would be CBT focused. You try to identify what are some of the unhelpful thoughts that get in the way of using it and try to resolve those. So it'd be a mix of things, I think. But there's lots of resources to get trained. I mean, in terms of, I know in this context of this research, they had a psychologist who was training that nurse therapist. There are lots of, you can leverage, much grander trainings out there that already exist to develop MI skills. And, it's a really useful, I think, approach in many health behavior change circles. Also increasingly like ACT. ACT has some good elements too. People know about third wave psychotherapy, acceptance and commitment therapy, where, you're not so much trying to change how people think about their situation or their difficulty, but more have them, kind of live in a value-based way in spite of what they're dealing with. I think that has many relevant perspectives for people with different kinds of sleep disorders.
Thank you, Dr.
Okay. They taught that when I was done grad school, so I didn't really get to learn it. So I had to learn it on the fly.
How is ACT adapted for the purpose of increasing adherence? You have the patient lead them to the realization that what they hope to achieve with the PAP is high value to them?
I don't know if it's been applied to, I was thinking of it more broadly as a psychotherapy approach to people with sleep disorders, but like if people were, what would be relevant, how ACT could be used in OSA, for example, or insomnia in particular might be if people are avoiding activities because of their sleep disorder. They're not participating in things to help them define what their values look like and how the way they're currently behaving is at odds with their values. They want to hang out with their family. They want to go do things. They're not doing those things as a result of their sleep disorder. So having them move toward value-based living would be an ACT perspective. I don't think it's been applied necessarily to PAP adherence, but. So maybe not relevant to this paper at all, but just something I bring up. So there you go.
Well, thank you, Roma. I don't see any comments in the chat or anything, so hopefully everyone has had a chance to ask their questions, but great paper, great discussion. Thank you.
Thanks, everyone.
Thank you.